Today we'll talk about endoscopic management for post-bariatric surgery complications. These are my potential conflicts of interest. A key component to understand bariatric surgery complications is understanding surgery alterations. The Roux-en-Y limb is an essential concept to understand. This limb was first used by Dr. Roux in 1898. Here we have several Roux-en-Y scenarios. On the right, Roux-en-Y hepatogastroenterology, which is used for resection of pancreatic lesions or plain Roux placement in the case of hepatogastroenterology. But in gastric bypass, there is a classic Roux-en-Y where a little pouch of stomach is left. There is a anastomosis with the jejunum, and here you can see the jejunal Y limb. Very important to distinguish from gastric sleeve surgery, where there is a part of the stomach, fundus and body removed and resected. The anatomy of the pancreatobiliary tract remains essentially the same in this situation. When there is gastric sleeve gastrectomy, there can be problems at the stapled suture line, but the most common complication is a fistula here at the fundus, as I will explain down the line. When performing endoscopy in patients with Roux-en-Y gastric bypass, it's very important to remember the endoscopic landmarks. Here you are observing the remnant gastric pouch, which is quite small. Then you observe here the anastomosis of the jejunum to the jejunum, the Y anastomosis. When you advance the endoscope into that limb going to the stomach, you can see the backside of the pylorus. You can enter here the stomach. This is the essential fundus of the stomach, which is closed. In patients with this type of anatomy, occasionally there can be a fistula between the stomach and the stomach pouch, which can lead to bloating, diarrhea, and significant other symptoms. And here we're doing a retroflexion, but that's at the antrum of the stomach. So these are classic landmarks to remember during endoscopy. So the first take-home message is to know the post-operative anatomy. Fistula dehiscence are the most common complications after bariatric surgery, and this is already known since the beginning of these types of operations. The incidence has varied over the years, but it remains a problem that must be addressed and known. In gastric sleeve, it's important to remember that the most common fistula is exactly at this location, because at this area there is some vascular supply deficit, and also there is some distal physiologic and mechanical obstruction due to surgery, which increases the backflow pressure, opening here a little hole or fistula. So the main second take-home message are that the defects after bariatric surgery that most commonly are encountered by endoscopists are fistula and adhesinces. Nevertheless, endoscopy is quite useful to take care of these problems, and we have a lot of different devices. We have through the scope clips, over the scope clips such as Ovesco and padlock. We have stents that are of different size and shapes, specifically designed to manage these types of fistulas in gastric bypass patients. There is the Endosuturing Device from Apollo. Always keep some glue in the type of fibrin glue or histoacryl in your endoscopy unit when you are dealing with these types of complications. And as you can see there is a large variety of devices. The Endosuturing device is quite useful to close leaks and fistulas, but the lumen needs to be sufficiently large for you to use this device. If the lumen is narrow, it's quite difficult to use it. For these situations, it's better to use, for example, clips or over the scope clips. As you can see here, this device is very useful to close a lot of types of fistulas, adhesinces, and perforations. The device is used as a versatile band ligation system. You attach the barrel to the handle of the endoscope, and then you apply the hook through the working channel, which is advanced. It comes out at the tip of the endoscope where you catch the string. The string has the clip attached to the transparent cap. In banding devices, of course, the bands are here at the tip of this cap. Once you attach it, you advance the endoscope into the mouth of the patient. Here, the string is being placed into the barrel, and now we are advancing into the upper esophageal sphincter, in this case, closing a fistula that's located in the stomach. Here, we're advancing the endoscope slowly, and you see here the fistula, which is suctioned into the cap, and you applied the over the scope clip. After you apply the over the scope clip, you can see that the device is released and there is a complete closure of this defect. Easy and a one-step procedure as seen on this video. Here is another example of another fistula in a patient who had adhesions at the level of the gastrojejunostomy. Here you can see the large defect, and here we are advancing the device into the stomach and closing the fistula. Gastropleural fistulas also occur after gastric bypass surgery, and this can be closed with over the scope clip. Occasionally using fully covered metal stents is also an option. There are stents that go through the scope or stents that are fluoroscopy guided. The success rate can be from 40 to 90%. The stents can migrate, but you can attach them using, for example, over the scope clips, traditional clips, or endostitching devices. You can also use multi-clipping to close defects as shown from this example. So the third take-home message is that there is a large variety of methods to close fistula and adhesinces in gastric bypass surgery. As mentioned to you, patients who have gastric sleeve have a defect that usually occurs at the fundus, mainly to distal physiologic mechanical obstruction and deficit of vascular supply. Here I show you the last two videos. One of the options is to do a dilation here at the level of the pylorus. This is the big defect, and by decreasing the outlet obstruction, you decrease the flow into that fistula. So in this case, it's important to advance into the duodenum. The wire is placed deeply in the duodenum. Then there is a balloon dilation, and you can see here it's a large balloon, and by decreasing the outlet obstruction, you decrease the chances of the fistula getting larger. And the other approach to treating these types of problems, fistula of the fundus in post-gastric bypass, gastric sleeve patients, is to do aceptotomy. Here you see the defect, and in this, look at the large defect, and here is the remaining stomach. You see how narrow it is, and in this moment aceptotomy is being performed so that the flow of food through the stomach remnant is going to be guaranteed and it's not going into the defect. So at this moment aceptotomy is being performed. In addition to doing the aceptotomy, you can also place a fully covered metal stent for a time so that the amount of opening here closes. We also have used endosponge to close this type of defect, but essentially the main understanding is to create a larger lumen for the contents, the acid and the food to flow. And lastly, here we show you a case of a patient who had a resection of a pancreatic cystic lesion in the presence of gastric bypass. This patient had a huge collection, and the collection, Entschuldigung, and here we show you a complex patient who had a complex problem after surgery, after gastric bypass. The patient underwent pancreas resection, pancreas tail, because of a huge mucinous cystic tumor, but during surgery there was a problem with the anastomosis, the gastrojejunal anastomosis with dehiscence, and a huge collection had formed. We performed deep enteroscopy, and during enteroscopy the jejunum could be seen, but you can see here the huge cavity. Therefore, the first step that we did was to place a direct endoscopic jejunostomy in the jejunum to guarantee feeding. As you can see here, we performed direct jejunostomy. After doing the jejunostomy, we performed over-tube directed drainage, endoscopic directed drainage of this cavity. Here you can see all of the food being removed from this cavity with the overtube. Then we performed a reanastomosis using a fully covered metal stent that was placed over a wire and over a tube, the tube from the overtube of the double balloon enteroscope. Here you can see the stent being placed to reconnect the jejunum to the esophagus, at the area where the gastric pouch had adhesions and was connecting to the cavity. This stent was then attached with the over the scope clip. After the over the scope clip was placed and the reanastomosis had been performed, we did percutaneous drainage of the collection, placing another stent, as you can see here in this graph. We went from the area of the percutaneous drainage placed from surgery, advanced a wire, performed dilation with the balloon, and after doing the balloon dilation, we inserted another self-expanding metal stent to guarantee drainage of this collection. So you can see still all the pus coming there, and afterwards the patient underwent placement of a catheter into this collection so that it could be flushed and cleaned on a daily basis. Here we're placing a nasocystic catheter across the external stent into the cavity, and we flushed it with saline for 2 weeks. In addition, we brought the patient every 2 days to look at the cavity and also placed vacuum therapy with endosponge to finally close the cavity. After 2 months, the patient returned and the collection had decreased, and we removed the stent used to do the reanastomosis. And after removing the stent, here we're removing the clip in the stent, we went back in and performed the final closure of a small fistula that was still in place by using an over the scope clip, as shown here. So this example shows that complex problems may be solved with the use of multiple endoscopies, tools, techniques, and devices. So we conclude that in patients with bariatric endoscopy, it's important to understand the post-operative anatomy. We need to understand the pathophysiology of defects, and there is a large multitude of devices and techniques to deal with surgical defects. Thank you very much, and I invite you to visit endocolab.com for quality in endoscopy, tips and tricks in endoscopy on a weekly and daily basis with videos, cases, and more. Bye bye.